and it's an interesting entity. We kind of some of them metastasize, very rarely metastasize, but they're usually considered benign. And then malignant lesions, I'm going to focus on follicular thyroid carcinomas, and also differentiated high-grade thyroid carcinomas. So I'm going to give you an idea about again, the classification and how to reach a diagnosis. Um, and as I said, having a flow chart similar to this, I find this one very helpful. It is very useful to classify your follicular lesion. The main thing you look at is invasion versus PTC nuclear features. Of course, if there's no invasion and no nuclear features of PTC, we go to follicular adenomas. If there is invasion, it's follicular carcinoma. If there is PTC features, your differential would be NIFTP. And here, as you can see, it says PTC-like nuclear features, and this is a new kind of arrangement or organization or classification of PTC nuclear features. So the PTC-like are usually nuclear features are usually associated with RAS mutated lesions, and you have the PTC nuclear features which are strong. These are BRAF type mutations, and you see that in the classic type of PTCs or follicular variant of PTCs. Okay, so I'm going to go over this as I move along. So follicular neoplasms, clinically, usually these are indolent. These are very slow-growing neoplasms. They are incidentally discovered as solitary, painless papillothyroid mass. And the first thing that is done in any of these cases or any of these patients is an ultrasound, followed by, once the classification of the thyroid scoring, a decision is made to do FNA sampling versus not. When FNA sampling is performed, these lesions are usually classified as Bethesda 3 follicular neoplasm or atypia of undetermined significance. I'm not sure how it's done other places, but mostly here in the US, the AUSs are usually sent for molecular testing, and the two most common ones are Afirma and Thyroseq, and these give you either a specific mutation, so it'll tell you there's a RAS mutation, a BRAF mutation, a RET mutation, or it will give you an idea about the chance of this tumor being malignant, right? And from there, the decision is usually to keep watching or do surgery. And that's where, our role comes along, is to diagnose these surgically removed lesions. And I can't emphasize enough how important it is to um, thoroughly sample and extensively sample these tumors. Okay. Um, and here, so this is what these it can is everything okay. Most of this is what they look like grossly. You could see here benign thyroid parenchyma on the outside and a very well circumscribed lesion. It kind of seems like you can pull that lesion out. It's very well circumscribed. The way in all institutions that I've worked in, and that's the recommendation, is to try to submit the entire capsule. Usually we don't really care about what's in the middle. Of course, submit a couple of slides of the tumor inside, but the most important thing is to perpendicularly section the capsule of the tumor and then submit them. You can submit 3, 4, 5 in each cassette and submit the whole capsule. This will give you about, like most cases, you'll get 10 or more blocks. But you will understand that this is the most important thing in classification, are to make sure there's no invasion. So, once it comes out, it comes to you on the slide. First thing you see is on low power is this well circumscribed lesion. You have a follicular pattern in the middle. It's right here. You can see it's very well circumscribed. Here you can see some normal thyroid parenchyma, but you can see that there's a huge difference between the morphology inside the tumor and outside. And in this case, there's a thick fibrous capsule. Okay. Next. So on higher power, you could see that again, this is a follicular pattern lesion. You can see the microfollicles. On low power, maybe you're not sure if there's PTC features or not, but here you could see a very thin capsule. It's basically compressed normal thyroid parenchyma, and here you have the benign thyroid. Again, looking at these capsules, when you see a more thick, fibrous, well-formed capsule, you should be more and more worried. Okay, so of course you can't have invasion of lesions with thin capsules, but the ones with thicker capsules are the ones that you should be very concerned about. And here are some examples. So here again, this is like the other one. You can see a very thin capsule and a microfollicular architecture in the middle. Here you can see another lesion with a thicker capsule. Here it's more fibrotic, it's thicker, and a microfollicular architecture in the middle, maybe a little bit of solid here and there. And of course, what you need to look for as well is when you in the thick capsules, you'll start getting these well-formed vascular structures right here with thick walled vascular walls, and you could see here the endothelial cells lining these. And this is where we look for angioinvasion. Okay, not inside the tumor. You're looking at angioinvasion within the capsule of the a thyroid lesion. Okay. And then next thing, so once you establish that you are dealing with an encapsulated follicular lesion, next thing you do is look for PTC features. And I'm sure all of you know what the PTC nuclear features. And these two examples here show kind of a spectrum, right? So you have here very well formed PTC features, very enlarged nuclei, cleared nuclei, kind of they have irregular nuclear contour, and there's crowding. On the other side, again, you do have enlarged nuclei. The nuclear membranes are a little bit irregular, but they're more hyperchromatic. So, when you look at PTC features, you don't have to find all of them, but you do have to find some. And the when the original NIFTP paper came out. Oh yeah, and sorry, this is also, they describe the nuclear features are as orphan annii, and coming from Egypt to the U.S., I did not know what orphan Annie is, but the orphan Annie was a very old cartoon, and you could see, once I looked it up, it actually kind of scared me. These are the eyes in these comics. They all had these clear eyes without any pupils or anything inside. So that's where the term orphan Annie nuclei comes from. But in the NIFTP paper, one of the things that they did was to create a scoring system for PTC nuclear features. And they divided into three categories. You have size and shape, where you're looking at enlargement, elongation, overlapping of the nuclei, membrane irregularities. So you're looking at irregular nuclear contours, nuclear grooves and pseudo-inclusions, and chromatin characteristics. So chromatin clearing and glassy nuclei. Uh, and they scored, they gave each category, if you have it, you give 1 point to each category. So if you have all three, that's very strong PTC features, like you see in right here in the bottom. If you have two, you will have PTC features, but they're not as strong. They'll be RAS-like. Okay, so that's where the term RAS-like PTC features comes from. So you will have, for example, enlargement, elongation, and maybe some grooves. If you have one, then you shouldn't think about 1 point, you shouldn't think about PTC features. Usually it's good to have that system in your head so you can go over everything. But once you have 2 to 3, right, that would be enough for PTC features in NIFTP. Okay. Um, Perfect. So let me just move on. So once we move, okay, here we go. So whoops. Here we go. Yeah. So NIFTP, once we decide that this is an encapsulated lesion with PTC nuclear features, we can call it a NIFTP. So NIFTP are the whole term is non-invasive, encapsulated, or well-demarcated follicular cell derived tumor with a follicular growth pattern and nuclei resembling PTC. They are of extremely low malignant potential. Most studies show that they are nearly benign. There'll be, a few cases, very rare cases of metastasis or showing up on in a lymph node. And the reason is because of sampling, right? You can sample the entire tumor, you can sample everything, but you're not looking at the entire tumor, right? So you might have missed an invasion that is not apparent on the slide. So that's why sampling and levels and of on the slides are very important. RAS is the main mutations for or the main driver for NIFTP. So about 52% of NIFTPs have RAS mutations, but this is not specific to NIFTP, right? You can have it in follicular adenomas, follicular carcinomas, and I'm going to show you a nice table after this. BRAF V600E basically excludes the diagnosis. So if you do have a thyroseq or a firma BRAF with a BRAF positivity, then you can't call it NIFTP. In some cases, there are NIFTPs that are classified that have, more than one mutation. So RAS and TP53 and TERT, but you need to be very, very careful calling a tumor NIFTP when it has a RAS and another driver, like for example, TERT or P53. These usually you see those in aggressive tumors, right? So once you see a TERT and a TP53, maybe hold off or just be very weary about calling it an FP. Okay, so here's a nice table of genetic alterations of NIFTP, and you could see first the first column is for NIFTP, then you have encapsulated follicular variant of PTC, follicular adenomas, follicular carcinomas, and the one between is classic PTC. And you could see all these follicular lesions have RAS mutations, right? The highest the most common driver in NIFTP or follicular variant of PTCs, follicular adenomas and follicular carcinomas are RAS. And these, of course, are divided into NRAS, HRAS, and KRAS. But this is the most common thing. And you could see the column in the middle is a classic PTC. These usually do not have RAS mutations. And then when you look at BRAF, there were 0 NIFTPs with BRAF mutations, right? In follicular variant of PTCs, you can see BRAF mutations, but again, if you look at the follicular adenomas, follicular carcinomas, and NIFTP, they basically that excludes the diagnosis. And TERT mutations, again, you can see it in NIFTPs, but again, there are some pathologists who will not call NIFTP with a TERT mutation, RAS and a TERT mutation. So just be aware of this. And one of the advances or the things that are available now is IHC to detect these mutations, right? So you have a RAS immunostain and a BRAF V600 immunostain. So sometimes you don't even need to send them or for molecular, you can easily do a BRAF IHC. If it's positive, then you can exclude the diagnosis of NIFP. So next, these are there are exclusion criteria for NIFT-P. There are things that have to be in the that you cannot have. So of course you need encapsulation and clear demarcation. You need less than 1% true papillae. And really, if you see true papillary structures, hold back, right? You don't have to call it a NIFT-P. You can call it something. And if you have any of these exclusion criteria, the way you're supposed to call a NIFT-P is encapsulated follicular variant of PTC. Okay, so if you have any of these criteria, so less than 1% papillae, if you have more than that, you can't call it a NIFT-P. No psammoma bodies. If you have psammoma bodies, you can't call it a NIFT-P. Less than 30% solid trabecular and insular growth pattern. So once you have most of the lesion being solid trabecular insular, you should be worried about going into a more aggressive a tumor like a poorly differentiated thyroid carcinoma. Nuclear, so you also need PTC features, so nuclear score of 2 to 3, no vascular capsular invasion, no necrosis. Necrosis excludes NIFT-P, no high mitotic activity, and the WHO recommends doing BRAF and NRAS IHC. And again, once you do BRAF and it's positive, then you shouldn't call it a NIFT-P. If you do NRAS and it's IHC and it's negative, you could still call it a NIFT-P. It's not an exclusion criteria at all, but it helps with the diagnosis. Okay. And again, as I said, it's always nice to have an algorithm or a flow chart, and I find this one very helpful. And it goes through everything, right? So encapsulated follicular lesion or well demarcated. If you do have that, you look for capsular or lymphovascular invasion. If you don't have that, then you go to the exclusion criteria that we just talked about, and so on until you get to the NIFT-P. And on the other side here, it tells you if you don't have these, so if it's encapsulated or well demarcated, if you have invasion, you call it infiltrative follicular variant of PTC, and so on. So this is in one of the textbooks. I think it's gosh, Dr. Bishop's textbook. If you email me or send me something in the chat, I'll send you the name. But I find this algorithm very helpful. Okay, so if I think now we're done with NIFT-P. Right. And just one thing before I move on. If you have this lesion without without PTC features, then you're looking at follicular adenomas and follicular carcinomas, right? So if you don't have the PTC features, you're in the follicular carcinoma side. Okay. Does anyone have any questions, or let me see if there's any questions in the chat. Wait, how do I do that? Okay.
John Dix is having one question about whether NIFTPs have mutations detected on Afirma or Thyroid. In
Yeah.
other words, can we have nuclear features of PTC without mutations?
So, so that's a good question. So the problem is it's cytology, right? So PTC features you can see it, but it's sometimes it's subjective, sometimes not real, right? Like or it's not I guess not very diagnostic, but not all you will not have mutations or yes so you will not have mutations on every cytology of PTC that's diagnosed as features of PTC without mutations. Yes, so I've seen that where you have PTC features. I'm not sure how strong, but you don't get any mutations. One of the reasons is that there are certain things that the Afirma and ThyroSeq look for. They also look for a an entire like not like an entire profile. So sometimes they will give you, for example, that there's a 50% chance of this being malignant, but it wouldn't give you a specific mutation. Does that answer your question?
John, uh, does it answer your question?
Well, can I? Yeah.
Yeah,
So
go ahead.
it answers my questions actually, but so on the cytology, I got this case right with all nuclear feature of PTC
Uh-huh.
very clear, and it's nothing like negative on the affirm
Negative for everything?
for everything.
Okay.
So is this something that can happen? And what should I tell the surgeon? Should he take it out, not take it out? I was
Yeah,
thinking about maybe sample issues. I don't know.
so that it could be sampling issues, but if you have very clear PTC features, you might not get a like you might not get a BRAF or an NRAS, but you should get a profile that is related to PTC. Telling what you tell the surgeon, I feel these are the results, but there are also certain criteria for how the like how high risk is this tumor for the surgeon, right? If it's a huge tumor that is causing compression symptoms, right? Then there's even if you don't get a malignant diagnosis, but it will be beneficial to take it out. If it's a small thing that has been there for years that they can watch, that's another option, right? But I've seen cases where it's called PTC, Afirma comes back negative, and for some reason it's taken out, right? And sometimes you'll get these follicular adenomas or something with very focal PTC features or something like that, which you got on cytology. So it is. I feel it's more a sampling issue than anything else. Okay. Okay, how to differential diagnose a follicular variant of PTC. So encapsulated follicular, so if you have, so basically encapsulated follicular variant of PTC is technically a NIFTP. Okay, because it's encapsulated, there's no invasion, and you have papillary thyroid nuclear features. The reason why you're not calling it a PTC is because you have one of these exclusion criteria, right? So once if you have, for example, samoma bodies or like some papillary structures, well, papillary structures maybe not, but for example, if you have some solid architecture or things like that, you shouldn't call it NIFT-P. And the term encapsulated follicular variant of papillary thyroid carcinoma is this term, right? Does that answer your question, Ali? Ali, okay. Okay, you can you can send another chat or we can talk again for sure, okay? Okay, so let me Okay, so I'll move on quick to the next thing. Okay, so now we've done the classification, right? We spoke about NIFTP, and again, if you have NIFTP, a follicular lesion without the PTC, it will also include, the follicular adenoma. Same, way to diagnose these. Okay, so so once if it's not encapsulated, you start getting you look for capsular invasion, and this is usually very difficult, right? It's very it's not very common to see a nice invasion like you see here. So in this example, you have a capsular invasion, very clear capsular invasion. So you have a capsule on this side, capsule on the other side, and the tumor is kind of pushed through the capsule, broke through, and mushroomed out. So it's kind of like a mushroom coming out of the capsule. And this is a very clear example. It's usually, not as easy as that, but every once in a while you get lucky and you get something like this. Then you have something, this pattern of capsular invasion, where you have, again, the capsule on this side, the capsule on this side, the tumor broke through and then mushroomed out, but you still have a secondary capsule. This I would consider capsular invasion, right? So it's going through. And then this is what we usually see. We usually see these small areas of capsular invasion that are very, difficult to see. So in this one, this is kind of interesting. You see here the capsule on this side, capsule on this side, but then the tumor is not actually breaking through. It kind of stops here, right? But if you look on the other side, right here, you see something or follicles that look like the lesion inside, right? So that means it went through, but we're not seeing this, right? And we're not seeing the exact breakthrough point. I would call this invasive. And really, if you find the same pattern lesion outside of the capsule, always call it invasion. What will help with these, for capsular invasion, it's very important to do levels, right? So if you do, when I see something that is suspicious, I usually get 3 to 5 levels. I cut through the block to see if the tumor went through. Okay, so these are the pattern of in capsular invasion. Of course, it can be very tricky to see. And now for vascular invasion, if you thought capsular invasion was difficult, vascular invasion is or angio invasion is even more difficult in thyroid. And there are a few, like different views of what to call angio invasion. Some people say if it's attached to the wall of the vessel, if there's fibrin around the tumor, if it's wrapped with endothelial cells. These things, make it angio invasion. And this is a nice example of angio invasion. You can see here the vascular space lined by endothelial cells. And you can see here the thyroid neoplasm right here going, and it's wrapped around with endothelial cells. If you can see it, there's a very thin rim of endothelial cells. This is, you call vascular invasion. And if you have areas that like that, you want to make sure, you can always do a CD31 to highlight the endothelial cells, and you can see here it's invading into the vessel, and it's wrapped by endothelial cells. Then you have things like this, where it's the follicles or the tumor is attached to the wall of the vessel. and you can see here the endothelial cells, and it's attached to the wall. Okay, sometimes you get fibrin clots around it, and that makes it positive. Okay. And here's another example. You can see here that it's going into a vessel and surrounded by a vessel as well on the outside. So sometimes they're small areas of vascular invasion or angioinvasion, and it's important for prognostically significance to count these angioinvasive foci. So you have usually if it's less than 4, the patient has a good prognosis. If it's more than 4, 4 or more, the patient has worse prognosis. So I usually count and give that number in my report. Okay, so other than CD31, can we use IHC to help us with capsular vascular invasion and so on? And really the answer is no. There's nothing you can really do to IHC to help you tremendously with finding out if there's vascular or capsular invasion. But right now the RAS, if you have a RAS mutated lesion, or if you run a RAS IHC, it can help you. So, for example, in the photo's not that great, but here, for example, you can see that there's a break here in the capsule, and when you do RAS IHC, you could see that it's positive inside and outside the capsule. Here, I think they might be showing a little bit of vascular invasion, and once you do RAS IHC, you could see that this is part of the tumor. In the bottom panel here, you have 2 follicular lesions in the lobe. We're not sure if this is the same one. If you do RAS IHC, they're both positive. You can say that they're the same, probably the same, or it went through the capsule. So that's something that you can use. I don't know how. I don't think I've ever used it and it worked, right? But I guess this is something that could be helpful in figuring it out invasion. Next. So what if you have like not full invasion or invasion that looks a little funny, or you can't make up your mind? So for example, something like this, you have a follicular lesion, the capsule is fine, and then you have this area that is kind of pushing. So you're not sure if this is did it break the capsule? Is this the same capsule that was pushed out? It's kind of difficult to figure out. Here you have the follicular lesion, you have a thick capsule. Follicular lesion is going into the capsule. Is it going into a vessel or not? It's so small, it's very difficult. You got levels, you can't figure it out. You're not sure if this is angioinvasive or not. Here again, you have this lesion with a very thick capsule. But notice here, the capsule, you can't find the end of the capsule, right? It's kind of, maybe this is a normal tissue. You can see here that the tumor is going through the capsule, and then it kind of pushes onto a vessel. And again, you get levels. You're not sure if going into the vascular space or not, or if it's going through. And then you have things like this, where you have piece of follicular neoplasm within, like it looks within a vessel, but it's just floating. It's not wrapped with endothelial cells. We can argue if it's connected to the wall or not, or something like this, for example, where you have all these vascular spaces with tumor kind of hanging out in there without fibrin around it or anything like that. What do you do with it? So you see these things and you can't make up your mind. You get levels, you do everything you can, and you can't figure it out. And most important thing, you sample this lesion as much as you can. This is where the new term, uncertain malignant potential comes in. And the definition in the WHO, here it says well-differentiated thyroid tumors with follicular architecture. So you have, this is called, FT-UMP. So it has follicular architecture. It's encapsulated and invasion remains questionable after thorough sampling and exhaustive examination. Again, if you have that, uh, if you sampled it really well and you're still not sure, this is a good time to use the uncertain malignant potential category. Usually these lesions will have a thick capsule, and this term should not be used if you did inadequate sampling. So, for example, the sample was not, the capsule was not entirely submitted, right? And you can't go back and do that. And I for me, I rarely use this term, and it shouldn't be something that you use commonly because a lot of these lesions you're not always sure if it's going through or not, but you should use that very rarely. And I think the in the WHO they give in different institutions it's about this diagnosis from 0.5% to 3% follicular lesions are diagnosed as uncertain malignant potential. Usually, if I'm not sure, I sometimes give a differential. So, for example, I sometimes get cases that are not sampled from outside institution. The entire capsule is not submitted. So I would say, follicular lesion, favor, benign, and then write in or follicular lesion, see comment, and then the comment I will give a differential, right? Because I'm not sure, I'll give follicular adenoma versus follicular carcinoma. And I just explained that I don't see any invasive growth or anything like that, but it wasn't sampled enough to call it something. Okay. So, yeah. So yeah, Mohammed in the chat is asking about CD61 for thrombin. Yeah, I mean you could I've never used it personally, but I would always use CD31 to see I think I would use both CD61 and CD31 if I used it, but. Uh, I think seeing the endothelial cells wrapped around the tumor is a very important part. But yeah, I've never tried it, so maybe I can try it to use CD61. Okay. Next, yeah, and then I might have not gone over that, but these follicular capsular follicular neoplasm are divided into minimally invasive. So if you just have capsular invasion, you'd call it minimally invasive. If you have angioinvasion, you call it angioinvasive. And if it's going everywhere, like this tumor here, we call it widely invasive. Okay, so now I'm going to go something that I really want to talk about, high-grade follicular cell-derived non-anaplastic thyroid carcinoma. I know it's a long title, but in the WHO, this is the new or newish, I guess, entity that has been put in. So prognosis of thyroid cancer, you have excellent prognosis on this side, and these tumors are PTCs, follicular thyroid carcinomas, and oncocytic carcinomas. These usually have excellent prognosis. Other end of the spectrum, you have the undifferentiated or anaplastic carcinomas. And then in the middle, you have poorly differentiated thyroid carcinomas. And okay, so poorly differentiated thyroid carcinomas. And I'm going to go quickly over what it is. Poorly differentiated thyroid carcinomas are invasive carcinomas, so you have a something that is like a PTC or a follicular thyroid carcinoma that it's going invading. But then you see solid trabecular or insular pattern of growth. Once you see that, you should really look at certain things. Loss of papillary carcinoma nuclear features is also something that is associated with poorly differentiated thyroid carcinomas, right? And then you look at the Turin criteria. Turin criteria, you need one of the following things: convoluted nuclei, mitotic count of more or equal to 3 per 2 millimeters squared or 10 higher power field, or tumor necrosis. I usually, if I only find convoluted nuclei, I need more. I usually call an increased mitotic count or tumor necrosis. If I see any of these, then I upgrade, and it has the solid or insular growth, I upgrade it to to poorly differentiated thyroid carcinoma. These usually you'll lose thyroglobulin. You usually will also lose TTF1, but PAX8 is usually left. And this is a nice example. You could see here the islands or the insular growth pattern of this lesion, and you could see here a lot of mitotic. So one here, one there, one over there, I think. So you have three in this field. Once you see that, it's a poorly differentiated thyroid carcinoma. But then we notice that there are these lesions that look like PTC, they look like follicular thyroid carcinomas without solid areas, but they do have increased mitotic activities and necrosis. But, a few years ago, we would call them PTCs. We might mention that there's necrosis or increased mitotic activity, or sometimes we just ignore it, right? But we just call it PTC or follicular thyroid carcinomas. But now studies have gone through and they found that these tumors with PTC features or follicular thyroid carcinomas with mitotic activity or necrosis have a worse prognosis. So here, this is the classification: differentiated high-grade thyroid carcinomas. There's presence of more or equal to 5 mitosis per 2 millimeters squared or 10 high power field, or tumoric necrosis. They will still have, so I said in the poorly differentiated thyroid carcinomas, you will lose PTC features or follicular thyroid carcinoma features. On these differentiated high-grade thyroid carcinoma, you'll still have it. You'll still have PTC nuclear features, oncocytic features, follicular features. You'll still have that. You'll also lose TTF1 and thyroglobulin. PAX8 is positive, and they lack the anaplastics, so they don't look ugly like an anaplastic thyroid carcinoma. So here's an example. This is a nice papillary thyroid carcinoma, clear nuclear features. But then when you start looking closely, here you have two mitotic activity, mitotic figures. And then when you look even further, you see that you have a lot of necrosis, right? But you still, here on this side, you still have the PTC, the papillary architecture and PTC features. So that's a papillary thyroid carcinoma with high-grade features, okay? And here, this is PAX8. And sometimes in the tumor, you'll do PAX8 and you'll see, or TTF1, you'll see in the areas that don't have these high-grade features, they're positive, but in the areas that have these high-grade features, you'll lose TTF1. This is another lesion here. You have a lesion that has follicular architecture. You could see it's everywhere, and kind of had, from low power, it could have PTC features. You get closer, it does have PTC features and mitotic activity, some necrosis here. Again, you can call this PTC. You could call it PTC classic type, or if you have a follicular variant, you can also call it follicular variant, PTC with high-grade features. This is another one. This is a follicular lesion. Here it becomes really, it looks more aggressive, and this has a lot of mitotic activity. This you can call a follicular thyroid carcinoma with high-grade features. And the alterations here, for when they're arising for a PTC with high-grade features, they usually have BRAF mutations. Sometimes they have RAS mutations if you have a follicular lesion. With poorly differentiated thyroid carcinomas, they usually have RAS mutations. Okay. And the survival for these is very similar to poorly differentiated thyroid carcinomas. So, once you diagnose that, it helps the oncologist to kind of maybe have a more stronger, like more aggressive therapy than anything else. Okay. So I'll leave the questions at the end. I just want to go through over a couple of cases, pretty rare cases. Okay, so patient, 25-year-old female, with a 1 centimeter left mid-thyroid nodule. Again, the next step is FNA or ultrasound. Came back as PTC, papillary thyroid carcinoma. They did a left lobectomy. And this is what we see. It's very well encapsulated. It has a thick capsule here. Inside it's not follicular, right? It doesn't have follicular architecture, but it has these large areas with kind of edema, maybe colloid, and then it has papillary features right here. Okay? So you have a diagnosis of PTC, but you don't have, you don't have molecular. Once you call it PTC, it's usually not sent for molecular. Okay, higher power again, pretty well. There's a lot of papillary architecture, well formed papillary structures. You have here. I don't know if you would call it PTC features, but there is some irregularity in the lymph in the nuclei. You have these balls of kind of squamoid or morules or islands or nests of squamoid type squamoid islands. Higher power here. So it I don't see clearing here. I don't see much enlargement. They are elongated. They are crowding. Maybe a few grooves here and there, but it doesn't look, like a strong PTC features. Okay, we did TTF1 was positive, but I don't know if you see it in the nest that I was talking about. It's kind of lost in that nest right here. PAX8 was negative, which is unusual. And this stain, I'm not sure if anyone can guess the stain, but it's very strong cytoplasmic positivity. And also, if you look a lot, if you look a little bit more, wait, let's see. Someone said in the chat. Oh, yes, Muhammad. Yes, that is beta-catenin, right? So if you look closely, you'll see that there's nuclear positivity of beta-catenin. And this is a very interesting tumor. It's pretty rare. We used to classify this as a PTC variant, but now we in the WHO, it's just called of oh God, there was it's not really known. Like it's outside of the PTC. And this is cribriform morular thyroid carcinoma. Before we used to call it PTC, cribriform morular variant, but now it's just cribriform morular thyroid carcinoma. And part of it is that it's got its own molecular, right? It's not associated with our classic RAS, BRAF, anything, or fusions or anything like that. It's just associated with beta-catenin or a pathway. A very strong association with FAP. Very rarely that would be the first presentation in a patient with FAP. Very strong female to male ratio, so it's 31 to 61 to 1. You have mixed growth pattern like we saw. It's cribriform, papillary, follicular, and solid. And of course, you see the squamoid morules. And I think those squamoid morules lose TTF1, and I think they also lose keratin. I'm not. I have to. I think it's just actually TTF1. Okay. In patients with FAP, they're usually multifocal or bilateral. In sporadic cases, it's usually a solitary nodule. They behave pretty indolently. They're not very aggressive, but they're pretty rare. So it's nice when you see one of those tumors. Next case, and this case, my fellow kind of Sarah Amin, who's currently who's going to head and neck pathology fellowship next year. She prepared the photos for this, so I thank her a lot. So patient is a 37-year-old female. She has a past medical history of hypothyroidism. Complained of lump in her throat, reported changes in her singing voice. So once you hear changes in the voice, you get worried about malignancy, right? Because of invasion of recurrent laryngeal nerve or anything like that. So that's one thing. It's on ultrasound, it's Thyroid 4, and it's a 2.4 centimeter lesion. FNA comes back as follicular neoplasm, and a total thyroidectomy was performed. This is low power, and what I want you to notice here is the lymphocytic infiltrate and fibrosis. So the background is lymphocytic thyroiditis or Hashimoto's or anything like that, but there's a lot of lymphocytic thyroiditis in this lesion. You look on higher power, again, you see all these lymphocytes, a lot of fibrosis, and then you have this kind of, it doesn't look like thyroid, right? It doesn't have follicular architecture, but you have those squamoid nests right here, a little squamoid nest with mucin inside, or I don't know if it's like colloid or something. But it doesn't look, I mean, if anything, you would think maybe, oh, is this a metastasis or is this anaplastic thyroid carcinoma? But you could see here it has a very, very like a background of fibrosis and inflammation. On higher power, again, you look at this inflammatory cells and you notice there's a lot of eos, right? A lot of eos, a lot of fibrosis, eos here as well. But the weird thing is, right, it's very unusual. You have these mucin cells right in here and mucin pools. But it doesn't, one thing I want you to look at is it doesn't look high grade, right? It doesn't have a lot of mitosis. There was no necrosis in the entire tumor, right? So it's I don't know if if you see salivary gland neoplasm, it kind of looks like a mucoepidermoid carcinoma, but it's in the thyroid. Could it be a MET? It's very unusual. TTF1 is positive, PAX8 is negative, which is also weird. You shouldn't have that. And P63 is very positive in these islands. So this is a very unusual, very rare case, and these are called sclerosing mucoepidermoid carcinoma with eosinophilia, right? If you think about it, it does look like a mucoepidermoid carcinoma. It has squamoid nest, it has mucous cells, and the only the thing that is very characteristic is it has a very strong fibrosis and a lot of eosinophils. There are fewer than 70 cases reported. It's associated with lymphocytic thyroiditis. The thought is it arises from ultimobranchial body remnants or solid cell nests like these that we encounter all the time in benign thyroids even. And it's like the one before, it's classified as tumor of uncertain histogenesis. It's negative for mammal 2. So if you want to rearrange it, if you want to know if it's a metastasis or invasion from the side or anything like that, from surrounding tissue, it is mammal 2 and negative. And it's usually indolent low grade, but there are aggressive lesions. And yeah, that's all the cases I have today. And that's it. If you have any questions, you can unmute and ask, or you can definitely put it in the chat as well.
Well, thank you so much, Mena, for a wonderful lecture.
Thank you. Thanks for having me.
Mishap. Wow.
Thank you. No, it's not a problem. Yeah, these things happen.
Okay. Well, I don't see lectures or questions. How to confirm the diagnosis of the last case? That was one question by Ali.
So how to confirm the diagnosis? It's usually by H&E, right? Like you look at it, you see the squamoidness, you see mucin cells, right? It stains for P63. It's not high grade, so you should exclude anaplastic. And then mammal 2 is negative, so you exclude metastasis from somewhere else. It's a tricky it's a tricky diagnosis, but if you see that and it has eosinophilia, patient has a history of Hashimoto's, this is the most likely diagnosis, and you'll never see that it will be confined to the thyroid. So that's how you get to it. It's you exclude everything else as well.
Well, wonderful lecture. As someone said, wonderful lecture. Oh, Allah. I love that.
ربنا يخليك. شكرا.
Thank you so much.
No problem.
Okay, guys. We'll see you next month, and hopefully we can figure out what to do with those